Hello.
Yeah.
Can you all hear me?
Good
Can you
morning.
see me? Good morning.
Yes, you are audible. Can you please share your screen, please?
Of course, I will. How do I? Okay. Can you see my screen?
Yes, sir. Please go ahead,
Okay.
Dr. Zaid. Thank you.
All right, then welcome, and thank you so much for giving me and my team this opportunity to talk to you. I want to say hi all around the world. As I see, this is a very diverse group, a very international group. So probably not enough to say good morning, but also good afternoon and good evening. So I would like to take this last opportunity of the morning session to talk to you about semi-automated digital quantification methods of hormone receptors, ERPR, and proliferation index markers, Ki-67, in invasive carcinoma of the breast. What I want to is give you a sort of key presentation into a historical review, where we are right now in the field and what the future potential can hold. I'd like to introduce myself to you. My name is David, and I'm a biologist, and I work at a company called MindPeak that I want to also briefly introduce to you. Our mission here in MindPeak is to make clinical routine diagnostics easier for pathologists, for you, with the help of artificial intelligence. We are an AI-driven company, software company based in Hamburg, Germany. It's a beautiful city. I would invite you, everybody, to come visit us here. We have 25 employees that have together 15 years of experience in AI, with many partners we are fortunate enough to work with. And I want to take this opportunity of this talk to give you, who are really experienced clinical pathologists, the opportunity to have a look into this quite new field of computer-assisted clinical pathology, and give you an outlook as to what you can maybe expect and what are the challenges right now that we are facing in this field. As you may or may not know, and this is also one of the top motivations for us to be in this field, the field of pathology, depending on where you are in the world right now, is facing some very disruptive changes, and it's undergoing some very monumental shifts. And on the one hand, what we see and what others see is the emergence of many new cancer cases. Of course, this is linked to the increase in population all over the world. And over the past 10 years, and the numbers show a significant increase of up to 28% in cancer case occurrence worldwide. Another statistic that really got us into this field is that the complexity of cases, not only the amount of cases, but the complexity of cases seems to be rapidly increasing, with newer diagnostic tools and the need for very fine specific treatments to be applied very specifically. The amount of slides per case that the pathologist would encounter is also increasing. This is from a study done by the University of Heidelberg in Germany, where they measured the amount of slides per case and registered over the last 15 years a 44% increase in the amount of work for the doctor. And on the contrary to that, maybe this is also something that, depending on your geography, are witnessing, is that depending on where you are, the number of active pathologists is not matching the rising tasks and the rising intensity and workload that they have to face. For example, in the United States, in a study conducted where they measured the number of active pathologists over the last 10-15 years, they noticed a drop of 18% in the number of pathologists, while on the same page you have an increase in the amount of cancer patients. You have an increase in the amount of intensity that the pathologist has to work on. And these are really the key driving factors that got us into working in this field. And where we want to tackle the problems and assist you, the doctors, the pathologists, the experts, into doing your work as good as possible for the benefit of the patient. So over the recent decades, since these trends have emerged, one of the key helpers that were identified is digitization. And on the one hand, this means the use of digital slide scanners in laboratories that help to get away from the physical microscopical slides and move on to digitized slides. And together with the second aspect being image management systems like PathoZoom that allow files to be shared across borders without physical limitations easily, to encourage the collaboration between different experts to share knowledge. This has been really a key driver to tackle these problems, is to be able to overcome these physical barriers and to work as good as possible on these cases digitally. But these two things together are not really enough to tackle the immense problems we are facing at the moment. And this is why around 20 years ago, we saw the emergence of computer-assisted vision tasks, where we use computer programs, where we develop software protocols to assist, again, you, the experts, in one of your most manually and labor-intense tasks, which is the manual assessment of stainings, of images. And one of those early approaches is called the classical computer vision. And they relied on handcrafted descriptors, being features of cells that describe their morphology and their appearance. One of the examples I would have here is if the doctor wants to assess the quality of the cell marked in red, what the computer vision would have is these descriptors, for example, the color, size, and shape of a cell that it would assess. And you would have to input manually at first that a color brown, meaning positivity, in this case towards progesterone receptor, a size of, let's say, around 10 micrometers, and a shape that is somewhat irregular to what you would expect in the beginning, would lead you to a diagnosis. In this case, it's a PR-positive tumor cell. And with cases that are fairly straightforward, that are easier, so to say, in this case, you would be right. And in this case, the classical computer vision could already help you form a diagnosis in some cases. But of course, there's limitations, and especially limitations to the approach of classical computer vision. The main problem here is that these features that we have to design and define don't really generalize well on edge cases and novel tasks. Meaning these features, they work very well in an organized environment when examples look more or less the same and just have to be run through a basic algorithm. But with more complex vision tasks, like the assessment of mitotic figures in H&E slides, this can get really difficult really fast. On the one hand, you see examples from mitotic figures, and on the right, examples for artifacts or structures that you would normally not like to have in the category of mitotic figures. And in these cases, the computer vision approach of comparing the morphology, comparing the size or the shape fails, because the key to solving these problems rely more on a more general approach, a more abstract analysis of the surrounding areas, for example. Another limitation of this classical computer vision is the use of different clones and different antibodies within different laboratories. In the example of PD-L1 non-small lung cancer, some labs or some approaches require using a clone SP263 that has a very intense border staining, very intense membrane staining, whereas the 22C3 clone is significantly weaker in the expression on the membrane positivity. That means already here, having a generalized approach to assessing the color and the shape would fail again, because the inherent quality of these two stainings are completely different. So the key problems here really are with the automated analysis using classical computer vision is that you have a huge variety in data, meaning tissue quality, every patient is different, every tissue quality is different. You have different scanners and microscope operating in the laboratories, and of course, staining procedures, staining protocols and antibodies vary so much between laboratories that a standardized approach for all of these using classical computer vision is impossible to achieve. This results really in a lack of robustness of these applications, meaning you have solutions that might apply for a very specific set of data, a very easy or clear set of data that it has been optimized for from the beginning. And maybe this could be that you would make an application for one laboratory and it could work there. But the problem is that you have no general application possible through this. And for each and every solution that you want to apply, you'd have to go back and redefine these descriptors and redefine the features to fit exactly the purpose they have to show for. And this is really limiting in the for the professionals, for the pathologists, but especially limiting for the programmers that work on these sets, because they have to do the same thing over and over and never achieve true generalization. So what's the solution? The solution in this case is called deep learning, and it's something that you may or may not have heard. It's fairly recent. And what deep learning means really is learning from examples. And one of the most well-known approaches of this deep learning is in the search for self-driving vehicles. And the approach here is that in the beginning, you have a lot of example images, a lot of data of cars and roads and road signs, and you give it to these very complex, very adaptable deep learning algorithms that are modeled to work very similar to the brain itself, where you have different nodes, different nerves or neurons firing with each other and forming one coherent output in the end. And the output in the case of self-driving vehicles, of course, would be the automatic recognition of the environment and the fast and secure adaptation of behavior on the road. Now, this is all very theoretical. Let's jump in. The breakthrough in deep learning really happened in 2012. Beforehand, all we had were these classical computer vision algorithms and a way to assess their efficiency and to assess their accuracy. It's a so-called ImageNet, which was a set of images that each and every sorting algorithm, visual sorting algorithm, was trained on. And this included, for example, cars, animals, and buildings, and everything you would see in the environment, and that would be very important and also, but also very tricky for a computer to understand and to categorize. And with these classical computer vision approaches, there very quickly was a threshold where the quality wasn't improving at all, no matter how much work they were putting into. So in the end, they always ended up at an error rate of 25%, 26%. And of course, as you may know, this is not acceptable at all in a medical or in a clinical environment where really the smallest things have an impact on the survival and of the benefits to the patient. But in 2012, with the development of these and the discovery really of these neural networks, of these deep learning algorithms, and also fast hardware, so faster CPUs and graphic cards, they were able to crack this barrier of the 26% error rate. And in that short period of time, really, we're able to get incredible results in terms of the error rate. It dropped from 26% only 10 years ago to under 5%, even 2% with these neural networks, which really shows the powerful capabilities of these networks in terms of learning and abstracting from the tasks. Okay, but as we are not really working in the convertible or in the tiger space, but in the pathology space, let's see what this means for digital pathology. At first, this means that with some of the initial problems that we faced with the computer vision, we can actually now deal with these, meaning because the neural network develops its own complex internal rules and that don't have to be set by the programmer beforehand without even knowing how it's going to look like in the clinical routine. But now it's the algorithm itself that teaches itself what is important and what to look for. Some of the problems that we had in the beginning with the differentiation between mitosis and not mitosis are now possible to task, because the complex internal rules, it teaches it to look beyond just the color and shape and size of a cell, but also the surrounding and the context and everything that up to now differentiates the computer from you, the professionals that have all this experience. So does this say we have mission accomplished and everything is good to go and basically I'm out of work? No, of course not. I mean, using the deep learning algorithms we have until now, we can already try and assist you in your work and already try and have a positive impact on your work and overall on the clinical outcome to the patient. I mean, you might say, okay, let's go, give me the program and let me start working. Let me actually reduce the time I have to spend on cases. But of course, there's still problems that we have to tackle and still difficult tasks. Right now, what we are working on in the AI industry applied to pathology is that we have these standard deep learning models that I introduced to you in the beginning that were initially developed to detect cars and trees and everything that the self-driving car has to find out on the street. But really, these networks are not specifically made for cars. They're just really good at abstracting information, at learning and improving on tasks until you have a good outcome. So that is the one side. The other side is that you have a controlled data set. And what that means, I will show you in the, want to show you now. One of the biggest problems that we are still facing up until now, and that will probably never go away in terms of the problem itself, are variance, is the variance in slide preparation. Meaning, as I mentioned before, every lab does it differently, every tissue is somehow differently, and in the end, when you have a look at 6 examples from 6 different labs, you get 6 completely different results in terms of the color spectrums, in terms of the quality of the fixation protocols, in terms of how the tissue is preserved. So this, if you think about what the computer has to achieve on these examples, to grasp the difference and to still try and make meaningful results out of these very different examples is really the key challenge. And this is something that we, as let's say technicians, really marvel when observing the pathologists and when observing how good the human brain and the human capabilities are of abstracting information, and how applying knowledge from one example can really benefit in the analysis of the other examples. I mean, the things we have to teach the computers right now are some things that the human brain is just really good at doing. So, of course, we don't not only have a variance in slide preparation, but also variances in digitization. I mentioned earlier the use of digital slide scanners, and every scanner is different. They all use different cameras and lighting conditions, which means you end up again with very, very different results, where maybe as a person, as a pathologist, you can work on all 3 examples and very quickly get an overview and be able to analyze the situation. But again, for the computer, this is really hard and requires a very methodological approach to this problem. So how do we do it? Or let's say, not only how do we do it, but just to clarify again of how difficult this is and how amazing is that the pathologists are able to do this. Pathology and clinical pathology sits right at the very top of task difficulty. For some stainings, for some cancers, it takes years and decades to perfect the approach to analyzing the samples and analyzing the stainings. But also for us, it sits right at the top of how hard it is to get meaningful and significant data to work on these AI-assisted solutions. Right now, one of the key limitations of even deep learning is these cases that involve using a lot of context information. One of these examples is when looking at progesterone positivity in mama tissue. On the right, you have an example of a cluster of tumor cells. Some are PR positive, some are PR negative. And on the left, you have an example of a PR positive benign glandular structure. And without the full picture and without the knowledge of having seen these examples for tens and hundreds of times, it's really hard, again, also going back to these descriptive factors, to differentiate these cells just based on their color or their morphology, because they all look big and they all look round and they are all activated in some sort. So here is really one of the key challenges still for the deep learning, to differentiate why one is the malignant structure that you have to detect and one is the benign glandular structure that you want to ignore, basically, or definitely, or at least want to treat differently and not detect as a tumor cell. So let me guide you a little bit as to how we try and approach these problems. Our deep learning architecture that we developed is called a fully convolutional neural network. And well, again, the digital pathology, as it being a very difficult field for machine learning, we are trying to tackle it with pre-made architectures. And we found that this is not only enough to be able to tackle the high variance in data, but inspired by how the pathologists work, we devised our own custom architecture, which we call FocusNet. It focuses on the cell level details on the one hand, meaning it observes single cellular structures, but it also focuses on the context in another pathway, similar to how the pathologist would actually tackle this project. So, but tackling again the issue of comparing two cells that are completely different cells but maybe look similar, this approach can help you to get a combined output and really get the most out of your results and the most accurate results. Again, so combining information about the cell morphology, but also the structural morphology of the tissue and of the context. Looking at the shape and color and the other information contained in the images, the neural network learns itself to associate cell organizations, in this case, to make more abstract groups, which then help in classifying them correctly. In this case, instead of just looking at color, shape, and size, what the AI would do is look at the relative organization of the adjacent cells and using this form its own diagnosis, giving you the output that this is in fact a benign glandular structure that is hormone receptor positive. All right. The way we constructed this network architecture, meaning it's the fully convolutional network, that means it is possible to handle input images of any size. This means that you can select small areas to analyze on demand, or we can use the same network to pre-compute all the results on the whole slide image and then show the results already once the slide is open. So again, being able to adapt to as good as possible to the clinical routine that you face in the laboratory, being able to analyze just a small cluster of cells or the whole the whole slide to get the diagnosis that you need and that you want for the patient outcome. So our approach, what we kind of do differently in terms of constructing these networks, is that we value data diversity always over data quantity. Meaning the AI is trained on a data set from always different scanners, different laboratories, and all the different staining procedures that we can get our hands on. And we always select and rate our new data to improve the AI based on those diversity criteria. So we believe that it would be better to have 10 very diverse examples than 1,000 ones that are quite similar. So the amount of learning you can get out of the diversity is really important. When approaching the training for a neural network, there are two basic approaches. So one being supervised learning, which means that when providing the data to the network, you also provide labels. In this case, it's shown and illustrated as class 1 and class 2. So you have, in the beginning, you have clusters of data, and you want to have a network that can actually make a sense out of these clusters of data. So what you give it to train are annotated, are these annotations, meaning you give it class 1 and class 2, and based on these annotations, it can form the diagnosis that these are in fact two very different clusters, and it can then try and move the knowledge that it acquired on this case onto all the other cases that you feed or that you want to train on. The other approach that is commonly used is referred to as unsupervised learning, meaning you omit all the labels entirely and also and only model the data itself and let the network figure out itself common structures in your data to represent which data points are similar and which ones are dissimilar. Of course, in unsupervised training, it's essential to guide the network towards learning proper representation by using a proper loss function and the right augmentations. Here's an example of different images. A neural network could detect similar tumor areas and associate them to being similar to each other while finding other areas which are dissimilar. It would look like this. In this case, the green areas are found to be matching and similar, and the red areas are further away in the representative space, so dissimilar. And without the need for labels, without the need for any annotations, these are already very significant informations that the network can teach itself based on the diversification of data that are given as an input. So what we do differently in this case is we have also supervised learning, which means that we train with labels, as I said. And in the case of this pathology application is we have an image, and all the cells that we want to recognize in the end, or that we want the AI to recognize itself, are labeled, are giving labels like tumor negative, tumor positive. We have immune cells and benign cells, all the different cells that the AI has to recognize in the tissue to then learn from that and give you the outcome. For example, inputting an image and you want to have the proportion score of positive tumor cells in this given area. And this is something that can be achieved very, very, very good through the supervised learning and through providing annotations done by trained experts and inputting those in the network. What we kind of want to do is combine these two approaches and get, let's say, the best of both worlds. So we combine the supervised with the unsupervised in a form of semi-supervised manner. And on the one side, and from the supervised learning, this helps us a lot to, this helps our AI a lot to find a robust initialization on the data, and alleviating also problems that are associated with label ambiguity that are associated with supervised learning. And then the supervised learning, on the other hand, picks up on these pre-learned features and refines the AI, especially in very difficult cases, to achieve then the high percentages of accuracy. The goal in the end, of course, is to get a product for the clinical routine that works just the way you want it and you need it. And for example, that could be then the analysis of big patches and the analysis of positive tumor cells, negative tumor cells, proportion scores, but also an analysis of benign structures. So really a product that fits the clinical routine where it has to perform best, and where also the biggest impact on in terms of increasing accuracy and reducing time and cost can be made. We are quite proud actually to have released our first product called Breast IHC, which passed the German laboratory accreditation test with a high accuracy of 96%. Right now we have one of the largest clinical studies in progress, and are aiming to receive our CE-IVD clearance within the beginning of next year. And I've been talking a lot to you, so I would actually like to take the opportunity and give you a demonstration as to how this could look like applied to in a digitized laboratory environment. So I hope the sharing of the screen still works now. I will switch over to our AI console and would like to demonstrate what I've talked to you about. So the single cell quantification of receptor markers and proliferation indexes on some live images. And of course, I want to show you not how it works 6 times on the same images, but really, let me refresh here briefly, how it performs when we have 4 different images from 4 different stainers and 4 different scanners. So let's jump into the first example. This is an image of a Ki-67 staining. And what we can do now is select our region of interest. In this case, I would go into this tumor cluster here and just zoom in, find an area that we are interested in. Then we select the analysis type. As this is a Ki-67 sample, I would select the Ki-67 algorithm, and now just click and drag to select my region of interest that I want to quantify. And now the AI is actually in real time analyzing this image, and after some seconds giving us a quantification of these single cells. On the left side, you can see the number of positive tumor cells, you can see the number of negative tumor cells. It outputs the positivity score for this area, and also the positivity threshold is something that, of course, you can still work with. But let's zoom in first and inspect the result. So what the AI, or what the task of the AI in this application is, on the one hand, to detect all significant tumor structures and label them accordingly as either negative or positive, and also, and most importantly, to avoid and ignore most non-tumorous structures. And in this example, we can see here that it labeled in yellow all the negative tumor cells, and in red the positive tumor cells, and it was able to ignore, for example, this non-tumorous structure, and also here. And but then if you, for example, let's say, if you want to look at a different example, we can move back to the gallery. So if you imagine in a digitized lab environment, this is where you would have all your cases that you would have to evaluate in the given time, and that you would have to, let's say, in a day. and you can easily switch between them at all times. Okay, going into the next example. Again, this is a completely different scanner and stainer, and the colors already look quite different to previously. This is again the Chi-67 example. I would select the Chi-67 algorithm, draw my region of interest, and after some seconds of analysis, we would get our result. In this case, we have a positivity of around 40% with roughly 100 cells analyzed. Again, you can zoom in and review your examples. And again, the goal here was to get the most of the tumor structures that you would like to analyze while avoiding the non-tumorous structures. Okay, let's check out another example. This is the red background is always, for example, a Philips machine. So again, selecting an area, selecting the algorithm you want to use for your analysis, and selecting your region of interest. After a very brief calculation time, now we have analyzed 370 cells. We got a positivity score of 18, and we can now zoom in to inspect the results. And you can see that there seems to be also some image artifacts here, but it looks like the machine was able to deal with that quite robustly. Also showing the benefits of using the deep learning with which performs much better on these problematic cases in comparison to the classical approaches. Now in here, for example, you could argue that some of the cells that have been analyzed as negative, you would maybe say that they're actually positive. And of course, this tool is only being supposed to assist you in your diagnosis, so you still have the possibilities to adjust a little bit the results. So what we have here on the left side is a slider for the positivity threshold that we can use to adjust a little bit, and we can adjust it to just the right point where these two cells that we thought were positive but were initially classified as negative are now positive. And it would also now apply the same threshold to the cells in the region of interest that also were maybe initially negative, but it also would have to be classified as positive, adjusted now our threshold to these images. Okay, I would like to show you one more example. Now in this case, moving here, let's say we don't want to analyze such a small region, but rather the whole area here. What we can do is, again, just selecting our algorithm. And let's now draw a really big region of interest. Of course, this is going to take a little bit longer because the images have to be sent through the servers, and depending on where you are and how good your internet connection is, this actually takes some time. The analysis by the AI of the image actually doesn't take that long, but it's really the sending the image to the servers that takes a lot of time. And I hope that the servers in this case will be able to manage. Oh, there seems to be an error. Maybe because I selected a lot of white area around accidentally. I'm hoping this time the server is able to get the results. But okay, so there seems to be a problem with probably the internet connection, then let's go further in the presentation. I would actually go back to my slides. So this was, let's say, this was our demonstration for a fully digitalized laboratory. But let's say you don't happen to be working in a fully digital environment yet. We also have a solution that lets you use artificial intelligence just with your microscope camera or your smartphone. It's called Web IHC. And you can use it by simply creating an account on our website. Actually, let's check it out ourselves. This is the platform. I will log out briefly so you can see how it looks like. You can always create an account. It's free. The first month, you can just upload your data and see for yourself the results. Quickly log in here. And how it works is you just have to drag and drop or copy and paste your images from the microscope and your smartphone in here. It works best, as a recommendation, it works best for images that have a 20x resolution. And of course, the better the image quality in terms of using good lighting conditions, the better is the result. I can also show you some examples that we have on here, some Ki-67 demo examples. Again, just as in the previous demonstration, you can see here how it analyzes on a single cell level a whole region of interest that we input in the beginning. On the left-hand side, we get the results, the amount of positive tumor cells and negative tumor cells. And this is really what I wanted to show you in the previous example where the servers, where the results couldn't be transmitted or the image couldn't be uploaded, is that you can not only analyze, let's say, a couple of hundred cells, but really 1,000 to 2,000 or so, thousands of cells. And again, it gives you the amount of positive cells, negative cells, and the proliferation score based on these numbers. You can again use a slider to toggle the positivity threshold. I can try this out in this example. So based on, if you want to adjust it maybe to fit your diagnosis on this image. What you can also do is do it individually for specific target cells. For example, if you think that this cell should actually be a positive tumor cell, just click on it and it turns positive. This one also, probably because I readjusted the positivity threshold. So these actually all tumor. And let's say a cell, you think a cell was maybe missed, that should be included. Let's say this one here that is hiding between the other tumor cell. You could just click on the area and a new annotation appears. So now you have analyzed your image, you have analyzed 1,500 cells and get a proliferation score of 38.6% that you can use then in your further on diagnosis. You can download your image, you can download all the annotations to share it with your colleagues, to use it in a presentation or to further collaborate with your colleagues on the patient. It's really simple. Just download and there you go. Let's check out another example together. These ones are I can show you, and you can already again see that the quality in the images is varying very much, and this one seems to be a lot worse actually than the previous example. Again, it analyzes within seconds the image that you input here, that you upload and copy. It gives you the amount of positive cells, negative tumor cells, proliferation score. You can adjust it, you can add, and it's really refined to be a tool that is helping you as good as possible in your daily routine in analyzing these Ki-67 proliferation scores. Let's have a look at it. One last example. And again, this is something that you are invited to try out yourself. You can always register and try it out for 1 month, even with your own data. Again, it works pretty fast, within seconds, and you can always adjust to your liking, basically, to get the perfect results. Okay. That would conclude my demonstration and my presentation to you. I'm fortunate, or we're fortunate, to have a very amazing team here in Hamburg with us, of very brilliant minded people that are working together and tackling these difficult problems. We have some of the best data science people and experts in the field of pathology working with us, advising us. So we're very thankful to be given this opportunity. I would like to conclude the presentation by saying, please get in touch with us. We would really like to collaborate with you, see what types of data you maybe have that are very interesting, and we're always looking to build collaborations all over the world. Get in touch via email, or just write us through our website or on LinkedIn. I would be happy to meet you. And yeah, thank you so much for your attention. Thank you for joining this call, and also thank you to the organizers for giving us the opportunity to present here. And I'm very much open to receiving questions from you now. So thank you very much.
Thank you, Dr. David Mudler, for speaking on behalf of Dr. Khalid Daifalla from Germany. For the information for the participants, Dr. David Mudler is the product specialist at MindPeak. It has been a pleasure to have you amongst us here in this conference, sir. And it is also good to know that MindPeak automates microscopical and pathological analysis with deep learning and artificial intelligence. Until recently, we are using the conventional light microscope. It has been the standard practice for the pathologist for examining the histopathology slides. However, digitization definitely affects the pathology workflow. And through Dr. David Mudler's speech, we understood that by the use of computers, this could be really helpful when it is difficult for the human brain to process so much of information, thereby freeing the pathologists, their valuable time that can be used by us to provide the correct diagnosis to the patient. So it was really a pleasure for us to hear you, sir. And thank you for making this topic really interesting and inspiring for pathologists. And it is really a wonderful thing to have you amongst us, sir.
Thank you very much.
And last but not the least, sir, it is a great achievement from your side that you have passed the German lab accreditation test with 96% accuracy, as far as I had gone through your presentation. That's a really great achievement, sir.
Yeah, we're very happy on that one also.
Yeah. Thank you, sir. So are there any questions to Dr. David? From any of the participants?
Maybe questions, but also I would be open to hearing your experiences of digitization. How far are you in your labs and in your current practices? And have you made maybe initial experiences with digitized labs and AI software?
So, sir, actually, I have a small doubt. Like, in the last pictures, in the last images that you have zoomed up and shown us, so what is the percentage of like false positivity? Like, for example, you have shown the Ki-67 index. So how far is it precise?
Thanks for the question. This is actually, I would say, one of the most difficult ones to answer, because this depends the most on the quality of the image and the quality of the data. So we kind of showed with the German laboratory accreditation test that under some circumstances we are able to achieve the let's say correct diagnosis by 96%, meaning we still have 4% left to improve, and 4% where we are encountering false positives and false negatives. So this is what we are aiming for, is to get rid of these last percents. But of course, as I showed you some of the examples where you end up with a very difficult lighting conditions, very difficult tissue conditions, sometimes the rate of these false positives can still be higher than what we managed to achieve in this one test. And this is why the data variety, having the data variety is so important to get these really, really difficult cases. Sometimes, yeah, you have, it really depends on what you're dealing with, but on the overall, we are already, at least when the products that we have already deployed, we are able to get it down to 3-4%, those remaining false positives.
Okay. Yeah. Okay. Thank you, sir.
Thank you.
May I ask a question?
Yeah, sure.
Sure.
Yes, wonderful presentation. I think the way to go for the future, it was an excellent presentation of all your material, and the slides, the way you spotlighted them and highlighted the calculation by the algorithm was excellent. I have two queries. One is, how do you calculate the error rate, and how did you bring it down to 2.5%? And the second question is, are your algorithms available for application across the board to other digital platforms? For example, if we use the website and access MindPeak for your immunohistochemistry AI platform, for example, either for Ki-67 or ER, how sure are you that it's going to work? Do we have to do anything else, do some specific processing, or what are your recommendations for that?
So maybe I would get to the second question first. In terms of recommendations, so far it has been mostly proven on in terms of the magnification on a 20x, and in the end, I think that refers to in the digitized environment, we often focus on microns per pixel or micrometers per pixel. That would mean that you have a resolution of 0.25 microns per pixel. So this is the magnification, the image settings where it actually performs best so far, and that we would always recommend of using. But there is at least a layer in the neural network that tries to tackle this by guessing. So if we don't have the information as to what magnification we are using, we have a layer that tries to guess it by itself. But again, using a magnification of 20x is definitely recommended. And of course, also having the best possible quality of tissue in your case to use for the analysis is also beneficial. But we are, I think, confident enough to say that it will work with acceptable accuracy on most, if not all, of the qualities that can be supplied in this case. So maybe only as a as a hard recommendation. So you can definitely use it and even try it out. And if you think that there's something maybe not perfectly working, it could even be helpful to get in touch with us so we can find out find out the reason for that. But I mean, as those deep learning or the neural networks were initially developed as driver assistants in the self-driving cars, here it's basically the same principle. It's used as a driving assistant. So our goal is not really to get rid of the pathologist, because we can strive to, but we can never really emulate so far the accuracy and all the experience that you as a professional bring to the table. So our goal is to be in the beginning a sort of like a driver assistant, like a assistant in your car that tells you, look at this area, this could be an area of interest, and maybe this is an example of a positive tumor cell, maybe this is an example of a negative tumor cell, to in the end make the diagnosis more quicker, especially in terms of the time you have to spend, because this is where a lot of the improvements can be done, tackling those charges. And now I've talked so much, I'm sorry, could you please pose the first question again?
Yes, how do you calculate the error rate, and how did you bring it down to 2.5%?
So this error rate that I showed on the slide, this is from a different network. This is historically at the time being one of the best neural networks available on this task, and how they were able to bring it down to 2.5%. This is an interesting question, because on the one hand, I can tell you that it heavily relies on the input data that you use, but also on the complexity of the neural network. So just as the brain gets more complex from a simple organism to a cat or dog and then to a human, also these neural networks kind of increase in complexity. They have more layers, they have more individual nodes that communicate with each other. So I think this is how they were able to bring it down. But then if you look in detail, there's this phenomenon called the black box. If you want to look in detail how the AI performed on the solution, it's really hard to it kind of operates like a black box. So it kind of operates like a self-enclosed organism, like a network that we can help and guide along the right way. But all the individual decisions that lead to an improved example, we can try and abstract maybe. But it's very, very complex to actually decode as to what made it better and what not. I would have to ask one of our data scientists probably to answer that question best.
So maybe I can say something about it. Hi, my name's Felix. I'm one of the founders of MindPeak. And just to make clear again, this chart that had the decreasing error rate to 2.5% in the ImageNet dataset, that was not our software. So that was general. That was the general decrease of error of the AI community that reached it through application of deep learning. We only measure against pathologists, and in the case of the ring trial, the German ring trial, there was a panel of pathologists, and we don't know the details, unfortunately, but it's for each lab the same. There's a panel of pathologists, and you send your slides in, your analyzed slides, the results of the slides, and it gets compared to this pathologist's panel, and it gets sorted into classes, and the classes are starting at 0%, that's class 1, and then depending on the tumor entity, smaller than 1% and also the staining, I think that it's 1 to 10% in the ER and PR case, and 10 to, I'm not 100% sure, but it has at least different buckets, and we are trying to meet those buckets in this case. So that is how the test is performed. And this is our network, yeah, but not the ImageNet chart. And concerning your first question, when you use our online software, that is a research use only product that you can use to get assistance. And you cannot be 100% sure that what the network outputs is correct, because we cannot control what you put in. It's just too much possibility of variance that you put in. And so it's a little bit of self-serving, trying out yourself. This is different when we come to the whole slide imaging environment, where we set it up for you and where we control the data and make sure that there's a quality assurance on the data, and then also an improved result.
Thank you.
Thank you, Dr. Felix. Yeah, so are there any more clarifications or questions that could be asked to Dr. David?
Well,
from any other participants?
I've got a brief outlook question. So, you know, pathologists are very practical people, because pathology and practical begins with a P. And when I get a biopsy, I take a look at it, I take the immunochemical stains, and then I count in my mind, and then I write the score down. That's the usual routine. So, and my question is, could you outline a possible future implementation, just a tool, how to serve in the characteristical pathological setting? We've got a microscope, we've got a camera, we've got a data system. And how would you bridge this gap between the microscope camera, and a diagnostic data system that we are usually in our daily routine?
Felix, I would get that. Yeah, please.
Yeah, maybe you mean the gap to the laboratory information system, or which gap are you referring to, Dr. Lübke?
So right now, I can take a photo, I can put it on a USB stick, I can put it into my computer, and then I will do it by myself. But I think this is a very important gap between the microscope and the software. And we have a lot of different data systems in pathology, including patients' data and photographic data and microscope data. And because this, in my mind, is the most practical next step to make this a tool that you can use every day.
Right. So, I think one step is already solved, and that is if you connect your microscope's camera directly to the computer, and you see through the microscope camera, then you can directly grab that image and paste it into the website, and read what comes out of it, and copy that into the report. If you have it on the same computer, you could do a copy paste of the result on the left hand side, and there's an extra window that shows the report in a way that you can copy paste it, and then you have some of the hurdles of this workflow gone. Any further integration, so if you want to have it even more fluent integrated in your workflow, it kind of requires then a whole slide setting, I would say. Yeah. Does that make sense to you?
Yeah, it bridges one gap, the gap between the microscope and the calculation. But you will never find a computer that it's open accessible for you, and which is completely combined to your patient's data, because usually those two data systems are separated.
So you mean you have, if you're using one computer, and in this computer you have for example, your laboratory information system open, then you could take from the browser the result and just copy paste it again into your other system. So that would be the way to work with it then, I would say.
One threshold is that the laboratory computer system has usually something like a firewall or security systems, but it's not possible to exchange patient data with the outside. So this is just a security threshold.
Sure.
And it's very difficult to overcome this. So more practical would be just a tool which can be which harmonizes with your own data system.
So in the whole site setting, everything is harmonized, of course. So everything is connected. You connect your image management system to the AI and to the laboratory information system, and via different APIs, information is exchanged. In this web browser session, there is the beauty of it is that there is no integration needed, that you can use it right away. And as long as you have both programs open on one PC, you don't need access to the laboratory information system and the patient data, as you're using all Windows tools like screenshotting and like copy and pasting. That only is a difficulty if you have two computers, of course. If you have two computers, one runs the laboratory information system and the other runs the website, then then you have this breach. But if it's on one computer, you can just use as described. You have a field in your laboratory information system where you usually write your report in, and you can just copy and paste text from somewhere else in it. The website doesn't access any patient data. It just receives an image from you that you grab somewhere else and upload.
Okay, well, maybe
try it out. I mean, maybe that's also then that explains itself maybe a little bit once you try it out.
Yeah, well, this would be the consequence. I would just try to open the browser and the laboratory system and see if it works. So that's what I will do.
Exactly.
I would actually post the link. I hope this works. I would post the link in the group chat because, of course, copying from the slide is a little bit difficult. So I hope you can use the link and see for yourself.
Thank you.